In this lecture presentation, we'll review the relationship between stress, immunity, and health. This is based on Robert Sapolsky's Why Zebras Don't Get Ulcers, chapters 4, 5, and 8. As always, I recommend having the slides nearby so you can take notes as we proceed through the lecture, and also the interactive study guide so you can complete it as we go. Let's start with an overview of the relationship between stress and illness. Those of you who like to watch the videos interspersed with the lecture material might consider pausing here to watch the video How Stress Can Make You Sick. When it comes to stress and illness, there are a lot of interacting factors that contribute to the relationship. As you can see in the image, health, stress, and various approaches to coping are all intimately related. Acute stress is not associated with any severe consequences. With that said, chronic stress can be linked to the development and maintenance of many health problems. This includes increased risk of metabolic issues as well as cardiovascular issues, such as diabetes, hypertension, heart disease, and stroke. There's also increased risk for digestive distress, which can lead to an increase in gastrointestinal disorders, such as IBS and IBD that we'll talk about later in this lecture. Increased inflammation leads to an increased risk of many diseases, and that is becoming more and more clear over time as researchers are recognizing the primary role that inflammation plays in the development and maintenance of many chronic diseases. Of course, chronic stress increases the risk of new health problems overall, as well as increased symptoms and decreased recovery and resilience from existing health problems. One of the ways in which stress impacts our likelihood of developing disease, as well as having exacerbating factors in regard to diseases that we may already have, relates to the impact of stress on appetite and weight. Stress is known to alter appetite, and many of you have probably experienced this firsthand or have observed it in others. This includes factors like stress eating, emotional eating, or conversely, losing one's appetite. Research shows that about 2/3 of people, when stressed, will eat more food, and that's referred to as hyperphagic. About 1/3 will eat less, which is hypophagic. Glucocorticoid hypersecretors, that is, individuals who release high levels of glucocorticoids in response to stress, are more likely to be hyperphagic after a stressful incident. Glucocorticoids, like cortisol, influence the brain in many ways. In terms of weight and appetite, one of those ways is reducing the sensitivity to leptin. Stress impacts leptin-induced satiation. The way in which this occurs is that CRH, corticotropin-releasing hormone, is released by the hypothalamus, which stimulates the pituitary gland to release adrenocorticotropin hormone. From here, the adrenals release glucocorticoids, which then blunts the satiation signal that leptin normally causes. This encourages not only appetite in general, but specifically appetite for comfort food. This is also mediated by beta endorphins that are released when stressed and that further increase appetite. Frequent intermittent stressors are the most likely to stimulate appetite. CRH reduces appetite, but that's a fast and short-lived response, about 10 minutes. Glucocorticoids increase appetite, and that's a slower response that lasts about 2 hours, so much longer after the stressful incident has occurred. As I mentioned before, hypersecretors of glucocorticoids are more likely to be hyperphagic after stress. They're also more likely to crave sweets in particular. Interestingly, this does relate specifically to the stress response. These individuals are not different than others when they are not stressed. Restrained eaters are also likely to experience a pattern of becoming hyperphagic when stressed. Restriction oftentimes leads to a compensatory binge when the individual is stressed, craving food, and perhaps not able to use the coping skills that they might use in less stressful situations. Another factor that influences whether an individual is hyper or hypophagic following stress is how quickly the liver can break down glucocorticoids. Another impact of glucocorticoids on weight specifically is that high levels of glucocorticoids encourage the storage of ingested food, and that is particularly true in terms of visceral fat, which is abdominal fat stored around the abdomen. People who tend towards fat deposition in the abdominal area are sometimes referred to as having apple shapes. People with apple shapes have higher risks because of the impact of fat on the liver. Fat is released from abdominal fat cells and goes straight to the liver, where it's transformed into glucose. From here, high blood sugar and insulin resistance can occur over time. We'll talk more about blood sugar issues on the next couple of slides in terms of diabetes. Unlike individuals who have a tendency towards abdominal fat, who tend to experience increased fat storage in the presence particularly of high insulin, which occurs during the recovery phase, individuals with higher distributions of gluteal fat, that is fat near the hip and the buttock, are referred to as pear shape. This is considered to be a relatively healthier distribution of fat and is more likely to occur if the individual is a low glucocorticoid secretor rather than a high secretor. Apple shapes have a higher risk of metabolic syndrome and of cardiovascular diseases compared to their pear counterparts. This is due to many of the reasons that I've just discussed, but also because visceral fat cells are more sensitive to glucocorticoids than gluteal fat cells. That means that visceral fat cells not only have more receptors that are sensitive to glucocorticoids, but that activation of those receptors activate fat-storing enzymes that lead to more fat storage in visceral areas. That means that there is increased fat around internal organs that can create problems, such as metabolic syndrome and cardiovascular diseases. One of the primary examples of dysregulated blood sugar and metabolic issues is diabetes. Diabetes can be subdivided into type 1, type 2, and, as of recently, type 3 diabetes. And we'll talk about each of these. Starting with type 1 diabetes. Type 1 diabetes is an autoimmune disorder, which we will discuss later on in this lecture presentation. In this case, the autoimmunity occurs because the body attacks pancreatic islet of Langerhans cells that normally produce insulin for the body. Type 1 diabetes is then characterized by insufficient insulin. These individuals oftentimes also have higher than normal levels of glucagon. So the pancreas is an organ that controls sugar levels and produces substances that release nutrients from food. In terms of blood sugar, the pancreas controls sugar in the blood with the hormones insulin and glucagon, which are produced in the cells that I just mentioned, called the islets of Langerhans. After eating, the pancreas releases insulin, which helps excess sugar move into cells so it can be used as energy or stored for later use. Insulin also tells the liver that it can turn off sugar production. In contrast, when blood sugar is low, the pancreas releases glucagon, which tells cells and the liver to release stored sugar into the bloodstream. Without regular insulin release, sugar levels continue to rise in the bloodstream, which creates significant issues. Organ damage can occur in response to blood vessel damage, which is further complicated by high blood pressure, which is very common with diabetes. It also can involve hardening of blood vessels and decreased blood flow due to atherosclerosis, which increases the risk of heart attacks and strokes, as we discussed in our stress physiology lecture last week. Another outcome associated with type 1 diabetes is diabetic neuropathy, which is caused when high blood sugar damages the nerves that send signals particularly to the hands and feet. It can cause numbness, tingling, burning, and even sharp pain for the individual who experiences it. In addition to diabetic neuropathy, individuals who experience high blood sugar that leads to cell death, that leads to blood vessel, nerve, and organ damage might experience diabetic retinopathy, which is damage to the eyes, particularly the retinas, and can lead to blindness, and diabetic nephropathy, which is damage to the kidneys. Glucose and fatty acids, as I've mentioned in the stress physiology lecture, circulate in the bloodstream, which increase the risk of atherosclerosis, which then increase the risk of clogged blood vessels that can lead to an increased risk of heart attack and stroke, due to the restricted blood flow and the potential for an embolism to travel to an artery and cut off supply. Type 1 diabetes is primarily treated with insulin. The timing of insulin depends on blood sugar levels, which are impacted by many factors, including food, stress, and a myriad of other factors as well. That means that insulin must be carefully timed and dosed in order to properly manage symptoms of the disease. Teenagers are known to have compliance issues with insulin treatment. Children tend to follow the direction of their parents, and adults tend to recognize the need to properly manage the disease. However, teenagers who are on the verge of being independent adults, but perhaps are not quite there in terms of the development of their prefrontal cortex and the recognition of the risks involved in dysregulated blood sugar, are less likely to carefully manage their disease, and therefore significant risk factors do occur during these years. Whereas type 1 diabetes is often diagnosed in childhood and has a strong genetic component, type 2 diabetes is more linked to stress. With type 1 diabetes, stress certainly impacts the disease process and also can complicate insulin timing in terms of properly managing the disease. In terms of type 2 diabetes, stress is considered not only to be an exacerbating factor, but a risk factor for the development in the first place. Stress promotes insulin resistance by increasing glucose and fatty acid mobilization in the bloodstream. Glucocorticoids make fat cells less sensitive to insulin. Therefore, people who have a less well-controlled stress response, that is, people who experience high glucocorticoid release in response to stress, tend to have more poorly managed diabetes. Unfortunately, they also tend to have the highest blood glucose levels. Type 2 diabetes involves a progression that eventually culminates in the failure of cells to respond to insulin. In the case of type 2 diabetes, it may be that the body does not produce enough insulin and/or that it is resistant to the effects of insulin. Unlike type 1 diabetes, not all individuals with type 2 diabetes will need insulin to manage the disease. With type 2 diabetes, instead of glucose moving into cells, the glucose and fatty acids circulate in the bloodstream. Therefore, more and more insulin will be released to try to overcome this issue. Eventually, the pancreas will burn itself out and those islet of Langerhans cells will die. Eventually, this person may meet criteria for type 1 diabetes because if they burn out all of their insulin-producing cells, there will be no cells left to produce insulin. Therefore, they will become insulin dependent. The treatment of type 2 diabetes depends on the severity of the symptoms. If caught early, lifestyle, diet changes may be sufficient for reversing and/or managing the disease process. In other cases, medications, including insulin, may be required. Interestingly, when it comes to type 2 diabetes, the cells die because they burn out, not because they starve. The number of fat cells is fixed, so weight gain involves distension of existing fat cells. They're full of fat, so they're not at risk of starving. Now, when it comes to type 3 diabetes, there is evidence that insulin is involved in the phosphorylation of tau proteins, which are involved in the formation of neurofibrillary tangles, a major part of the pathophysiology of Alzheimer's disease. Additionally, there's evidence that insulin plays a foundational role in the formation of beta amyloid plaques, also a significant part of the pathophysiology of Alzheimer's. The hyperglycemia associated with high blood sugar leads to increased oxidative stress that impairs mitochondrial functioning and increases inflammation. Insulin resistance may also impair synaptic and neuroplasticity by altering these neuronal structures. This helps to explain the correlation between Alzheimer's disease and lifestyle factors such as a sedentary lifestyle and a poor diet. Essentially, there is current research, such as Candamala et al. 2017, that suggests that a form of metabolic disease, that is, insulin resistance and/or diabetes, that selectively involves the brain may manifest as Alzheimer's disease, and therefore, Alzheimer's disease may actually be a manifestation of type 3 diabetes. I also want to note that there are other forms of diabetes that are not discussed here, including gestational diabetes that can occur during pregnancy, and diabetes due to other causes, such as cystic fibrosis. In addition to blood sugar dysregulation and other metabolic issues, chronic stress can lead to gastrointestinal disorders. Those of you who prefer to pause the lecture recording to view the required videos might pause here to watch the video IBD versus IBS. So as we know from the stress physiology video, part of the sympathetic nervous system response to stress is to divert energy from the digestive system to other survival-oriented uses. Therefore, it shouldn't be surprising to hear that many gastrointestinal disorders are strongly affected by stress. Let's start with IBD. IBD stands for inflammatory bowel disease, which is considered to be an example of an organic gastrointestinal disorder. Organic gastrointestinal disorders also include peptic ulcers that we'll talk about on the next slide. The term organic refers to the fact that the disease can be validated or quantified through some kind of standardized biological measure. Non-organic disorders are referred to as functional, which includes the inflammatory bowel syndrome that we'll discuss next. When it comes to IBD, there is an autoimmune component, so it does appear to be immune-mediated. By immune-mediated, I mean that it refers to an overactive immune system. There is some disagreement about which types of inflammatory bowel diseases are immune-mediated and/or autoimmune in nature. Autoimmune refers to the body attacking itself, which we'll talk more about later in this lecture presentation. The research seems to suggest that Crohn's disease seems to have more of an immune-mediated feature, whereas ulcerative colitis appears to have more autoimmune properties. IBD is essentially an umbrella term for gastrointestinal disorders that appear to be organic in nature and involve chronic inflammation of the digestive tract. Both Crohn's disease and ulcerative colitis involve symptoms such as abdominal pain, fatigue, weight loss, and diarrhea. Whereas Crohn's disease can occur anywhere in the intestine and in any layer of the intestine, ulcerative colitis refers to inflammation and ulcer formation in the innermost lining of the colon. For Crohn's disease, these areas of inflammation and scarring can be intermixed with healthy parts as well. With ulcerative colitis, on the other hand, the areas that are affected are continuously inflamed. IBS, which stands for irritable bowel syndrome, is an example of a functional gastrointestinal disorder that is also known as spastic colon. There is strong evidence that IBS is related to stress. One of the primary lines of evidence that is used to support this suggestion is that individuals who have IBS do not experience symptoms while they are asleep, and presumably not stressed. When it comes to IBS, individuals tend to have more sensitivity to stress and/or higher reactivity to stress. There is evidence that suggests that IBS represents dysregulation of the brain-gut axis, as well as disturbed serotonergic mechanisms. In terms of the brain-gut axis, this is mediated by the vagus nerve, and there is some evidence that people with IBS have an imbalance between sympathetic and vagal functions. It may also occur as a result of gastroenteritis causing inflammation that may somehow change visceral sensitivity. In these cases, it's referred to as post-infective onset. The serotonergic mechanisms appear to particularly relate to the distribution and activity of serotonin 3 and 4 receptors. IBS can be subdivided into multiple types. People who are prone towards constipation may get the diagnosis IBS-C, whereas those more prone to diarrhea are more likely to get IBS-D. There is also IBS-M, which stands for mixed constipation and diarrhea. These individuals may vacillate between diarrhea and constipation over time. It's also possible that an individual may vacillate between having a primary constipation type to a diarrhea type later in time as well, in which case the diagnosis may change. There's also IBS-U, which stands for unclassified, and is for individuals who do not fit neatly into one of the other three types. The tendency towards constipation or diarrhea has to do with contractions of the colon and the direction that the feces moves. Constipation occurs if the contractions are disorganized, such that the feces cannot properly move through the colon. Diarrhea occurs if the colon contracts in the regular direction. It becomes diarrhea rather than properly formed stool because too much water is absorbed into the intestines and there is not enough time for it to be absorbed into the stool. Therefore, the person passes both the feces as well as the additional water. Another interesting feature of IBS is that individuals who are diagnosed with this condition tend to be more sensitive to visceral pain compared to cutaneous pain. That is, pain around the abdomen compared to skin and touch-related pain. There is then a vicious cycle that occurs, where the individual, because of dysregulation of the gastrointestinal processes, experiences additional gas formation. This gas leads to distension, which activates the sympathetic nervous system because it's stressful to the body. From there, the body, in response to stress, further dysregulates the digestive process, which creates more symptoms and more pain. Research suggests that trauma in childhood greatly increases the risk of later development of IBS in adulthood, which also speaks to the epigenetic phenomenon of early childhood adverse experiences and the impact on health in the lifespan, as well as to the relationship between stress and particularly functional gastrointestinal disorders. As stated on the previous slide, another example of an organic gastrointestinal disorder are peptic ulcers. Ulcers are sores or holes in the wall of the stomach or of a nearby organ. There are multiple types of ulcers that are named depending on where they are located. Gastric ulcers occur in the stomach, esophageal ulcers slightly above the stomach, in the esophagus, and duodenal ulcers slightly below the stomach, at the border of the stomach and the intestines. Duodenal ulcers are the most common form of peptic ulcer. Stress does not directly cause ulcers to form. However, it does make them more likely to occur, more virulent, and the body is less able to defend itself against bacteria, viruses, toxins, and any other foreign invaders. The stomach is coated with mucus to protect against stomach acid. It's also important for ensuring continuous blood flow that delivers oxygen and nutrients, as well as removing toxic substances. The increase of oxygen radicals can trigger an inflammatory response that further reduces blood flow. The mucus layer is also important for regulating gastric motility. So how does stress get involved? Stress leads to dysregulation of gastrointestinal structures and functions, which increase the risk of ulcer formation. Some of the ways in which this occurs is through degradation of that mucus layer that coats the walls of the intestines and the stomach. This occurs not so much because the mucus layer is attacked in any way, but because the repair process, where the body is continually dealing with putting down new mucus layers and repairing whatever occurs during the day, does not occur when the individual is under stress. These repair functions are mediated by the parasympathetic nervous system that can't get activated as long as the sympathetic nervous system is in overdrive. Stress also leads to changes in terms of oxygen flow and oxygen scavengers, which leads to an increase in free radicals over time. It also dysregulates the immune response, can lead to changes in prostaglandin levels, and also can change contractions. In terms of prostaglandins, these normally help heal wear and tear on the gut by increasing blood flow. However, glucocorticoids inhibit synthesis of prostaglandins. Therefore, they can't do their job in repairing this normal wear and tear. Another factor is that stress typically diverts blood from the digestive system to other areas of the body, and it skimps on gastrointestinal defenses in general. Therefore, the highest risk for ulcer formation is actually during the recovery period from stress, when the body is exhausted and can't protect itself from acid, from bacteria, or from oxygen radicals. Another factor that plays into the risk of peptic ulcers is the presence of Helicobacter pylori, more commonly referred to as H. pylori. This bacteria is present in many, if not most, if not all individuals, and is linked to an increased risk of ulcer formation. 30 to 65% of peptic ulcers have some psychosocial contribution, like stress. Stress increases the risk of ulcer development about 2 to 3-fold, and is most likely to occur in response to many intermittent stressors, again because ulcer formation is most likely during the recovery period. Therefore, if there is frequent recovery from stress, there is heightened likelihood of ulcer formation over time. Before we begin discussing autoimmune diseases, it's important to have a basic understanding of the immune system. If you prefer to pause the lecture recording to view the videos, you might pause here to watch the video, How Does Your Immune System Work? So let's look at the immune system. First, Robert Sapolsky, who is the author of our current book, is an expert in psychoneuroimmunology, which is the interaction of psychological and physiological variables and their impact on immune functioning. It looks at what strengthens and what weakens the body's ability to defend itself against disease. Essentially, it's psychology plus physiology plus immunology. And that's what we'll be discussing in terms of stress in the immune system on the next slide. The immune system can be subdivided into innate and adaptive immunity. Innate immunity refers to the immune system we are born with. There's a rapid response, and it consists of protections that are offered by the skin and mucous membranes, as well as by immune system cells and proteins that are presented in the image on this slide. White blood cells, referred to as leukocytes, include lymphocytes, monocytes, and granulocytes. Leukocytes are also referred to as white blood cells. They are the body's mobile defense system that's called to action when foreign invaders are detected. They're created in bone marrow and circulate through the bloodstream and the lymphatic system. Their job is to constantly screen blood, tissues, and organs for suspicious signs, which often involves looking out for antigens, which are basically molecular targets on the surface of invaders. Unfortunately, in the case of autoimmune disorders, these targets can be presented on potentially native ones as well. We'll discuss that more in just a bit. So, when phagocytes trigger an immune response, macrophages and dendritic cells travel in the bloodstream in order to find and kill foreign cells. They transmit this information to the lymphocytes, which include T cells, B cells, and natural killer cells. Monocytes, as I mentioned earlier, include macrophages and dendritic cells, and their job is to travel in the bloodstream to find and kill foreign cells and transmit that information to the lymphocytes that we'll discuss next. Granulocytes include neutrophils, eosinophils, and basophils, which we will not be discussing in this lecture. So let's go back to T cells and B cells. T cells have innate and adaptive functions, and the T comes from thymus gland. T cells, while they are produced in bone marrow, then move to the thymus through the bloodstream. T cells are found in tissues between the body's cells. They begin killing off infected cells after they're alerted by the monocytes. T cells release cytokines that help activity of other immune cells. Their job is to detect cells infected by viruses or tumorous cells and destroy them. Some T cells can actually remember how invaders were defeated and then become part of the adaptive immune response, and these typically are referred to as memory T cells. B cells also have an important job in terms of the immune system. B cells are named because the B comes from bone marrow, where they are made and where they mature to become specialized immune system cells. B cells are also found in tissues between the body's cells, and they are activated by T helper cells, and together they begin producing antibodies that match the antigen, that target, on the pathogen surface. B cells are activated by T cells that transform into plasma cells that can then produce antibodies and release those antibodies into the blood. Some activated B cells also can become memory cells that then are also part of the adaptive immune system. Antibodies are proteins that the immune system uses to neutralize pathogens. If you have antibodies, you're more immune to whatever virus, bacteria, or other foreign invader these antibodies are designed to fight. Meanwhile, while your B and T cells are fighting whatever foreign invader is causing problems in your body, you might be experiencing a fever and inflammation. These are both natural responses, and they're important. Fevers warm the body to reduce spreading of bacteria and viruses that typically do not replicate well and do not survive well under conditions such as heat. The inflammation is also an important immune system response. While it is very adaptive in the short term, when it is prolonged, it can be problematic. One of the best ways to measure innate immune responses is through measurement of C-reactive protein. Proteins flow to the site of the infection or the foreign pathogen and cause inflammation, and that's what C-reactive protein is measuring. It's actually good for predicting the risk of atherosclerosis because plaques stick to damaged vessels. In addition to the cells that I've already discussed, natural killer cells are an innate part of the immune system. Their job is to destroy the invaders that B and T cells cannot recognize and/or can't destroy on their own. They specialize in identifying cells that are infected by a virus or have become tumorous. The last type of cell we'll discuss here are mast cells, which are also part of the innate response. They play a critical role in the defense against pathogens as well. Mast cells release histamine and other immune mediators. Glucocorticoids inhibit mast cell degranulation and mediator release, which is one way that glucocorticoids bring down inflammation in the body. As already stated, immunity is what we are born with. It's nonspecific, and we share it with the rest of the animal kingdom. Our innate immune response is to flow to the site of infection or to the foreign pathogen to fight the microbe, which again causes edema, the technical term for swelling or inflammation. Acquired immunity, therefore, is our learned response. It's our ability to adapt to pathogens and to learn how to defend against them. As I mentioned before, antibodies are proteins that are developed to match antigens. And similar to a neurotransmitter into a receptor, antibodies have a lock-and-key design where they are specifically designed to match the foreign pathogen. This is the foundation of vaccinations, which are also referred to as inoculation. The idea is that a small amount of the foreign pathogen is introduced to the body so that the adaptive immune response can be developed, so that when the individual is exposed to the full pathogen in the future, the body is better prepared and more efficient in mounting an immune response to that foreign invader when needed. So how does stress influence the immune system? When an individual acutely experiences stress, innate immunity is particularly enhanced at first. Immune functioning is enhanced for a very short period of time after the initiation of the stressor, for about 30 minutes. Chronic stress, in which there is increased glucocorticoid release over time, will eventually lead to immunosuppression, which generally is about 40 to 70% below baseline. There's a more pronounced effect on T cells because the more cell-mediated immunity disruption than there is antibody-mediated disruption. Chronic stress also leads to the suppression of the formation of new lymphocytes, and additionally take lymphocytes out of circulation more quickly. That is, they are either stored and/or diverted to another site of action. Chronic stress also inhibits the release of chemical messengers, including interleukins and interferons. This leads to circulating lymphocytes becoming less responsive to the alarm signal over time. At high levels, lymphocytes are actually killed off in an indiscriminate manner. Whereas with a subtle rise, these cells may also be targeted, but rather than being indiscriminate in nature, the body will target old and ineffective cells, which is actually quite adaptive. Killing lymphocytes that are old and are ineffective is really immune enhancement and protects against autoimmunity. So you can see that stress is not inherently bad, but high levels of chronic stress can take an adaptive function and take it to the extreme such that it is highly problematic. Chronic stress also activates sympathetic nervous system hormones, beta endorphins, and corticotropin-releasing hormone in the brain. This also suppresses immunity in unknown ways. Unfortunately, CRH stimulates ACTH, which again leads to the release of glucocorticoids, and a vicious cycle occurs, whereby more stress leads to more glucocorticoids, leads to further suppressing immunity, which in and of itself may lead to more stress because the person is more vulnerable to infection and other problematic bodily outcomes, such as increase in visceral fat production, increase in metabolic issues such as blood sugar dysregulation, increased risk of cardiovascular dysfunction, and increased risk and severity of various gastrointestinal disorders. Thankfully, the body is typically good at differentiating itself from foreign invaders. Unfortunately, some individuals will experience autoimmune disorders, whereby the body attacks itself in some way. There is no singular contributing factor to autoimmune disorders, but research suggests some combination of genetics, overactive mast cells, and some post-infection phenomena. Unlike an allergy, where an individual overreacts to a foreign compound, that is, an antigen, this is an IgE antibody response. Antigens, again, are substances that trigger an immune response. An allergen is a special type of antigen that causes an IgE antibody response. Autoimmunity, however, is a response of the host to an antigen of the host. Autoimmunity is the presence of antibodies in T cells that attack normal and healthy parts of the body. They develop when autoreactive B lymphocytes, sometimes referred to as autoantibodies, and T lymphocytes cause issues and/or damage to organs and tissues that contain the autoantigen. Autoantigens are also referred to as self-antigens. Antibodies and T cells that recognize autoantigens are referred to as autoantibodies. The most common antibody test is called an ANA, which stands for anti-nuclear antibody. ANAs are often found in the general population, even in those without autoimmune disorders, but generally to a much lower extent. With systemic autoimmune diseases, autoimmunity targets are expressed throughout the body, such as in joints or muscles. There can also be organ-specific autoimmune diseases, where the self-antigens are typically particular cells or tissue-specific. For example, systemic autoimmune disorders might include rheumatoid arthritis and lupus, whereas organ-specific autoimmune disorders include conditions such as Hashimoto's thyroiditis and Graves' disorder, which attack the thyroid gland, type 1 diabetes that attacks the islet of Langerhans cells, the pancreas, multiple sclerosis that attacks myelination of the central nervous system, myasthenia gravis that attacks the neuromuscular junction, and other specific autoimmune disorders that will be presented on the following slide. It's important to note that one aspect of the stress response is to return to immune activity baseline or below. If glucocorticoids are low, or if the person is less sensitive to them, the body struggles to return to baseline. This can lead to an increasingly higher risk of developing and/or exacerbating an already existing autoimmune condition. Chronic inflammation disrupts normal functions of the cells and tissues and creates downstream problems. The inability to properly recover from the stress response may represent lifelong issues, epigenetic changes, and/or dysregulation due to the chronic stress itself. Whatever the cause, inflammation is a very common piece of the autoimmunity puzzle and is associated with many of the debilitating symptoms associated with autoimmune disorders. Due to the relationship between immune activity and autoimmune symptoms, immunosuppressive medications are a common approach to treatment. Glucocorticoids, for example, which suppress immune activity, are used to help with some of the symptoms of autoimmune diseases, such as inflammation and the resulting pain that can occur. Immunosuppression will typically reduce symptoms, but of course, they also block immune responses, which leaves a person vulnerable to other pathogens. This can allow reactivation of a latent infection and can also reduce the person's ability to fight a new infection. Some immunosuppressant medications that are prescribed for autoimmune disorders, in addition to glucocorticoids, include medications such as Enbrel and Humira that do not directly affect glucocorticoid levels, but instead are TNF-alpha inhibitors that take a different approach to immunosuppression. There are more than 100 known autoimmune diseases. We'll cover a few of some of the more well-known examples. Please keep in mind that each of these disorders is associated with a much longer symptom profile than is listed here. Celiac disease is an example of an autoimmune disorder that is triggered by the presence of gluten, a protein contained in food. Gluten leads to inflammation, which then leads to damage to the small intestines that leads the person to have poor nutrient absorption that can further damage not only the intestines, but the body in general. Hashimoto's thyroiditis, as mentioned on the previous slide, is an example of a specific autoimmune disorder that attacks the thyroid gland and is the most common cause of hypothyroidism. Graves' disease, which was also mentioned on the previous slide, is actually the most common cause of hyperthyroidism. Type 1 diabetes we've already discussed, and as a reminder, what happens here is that the body attacks islet of Langerhans cells in the pancreas that produce insulin and lead the person to be insulin dependent because they can no longer produce their own insulin supply. With lupus, the body attacks tissues and organs and leads the person to widespread issues with joints, skin, and organs such as the kidneys, the brain, the heart, the lungs, and their blood cells. With multiple sclerosis, the body attacks myelin, which leads to communication problems in the brain, spinal cord, and optic nerve. Myasthenia gravis, the body attacks at the neuromuscular junction, which can lead to, amongst other things, muscle weakness and fatigue. With rheumatoid arthritis, the body attacks tissues in general, but particularly the joints, which leads to painful swelling and, over time, if not properly managed, to joint deformity as well. Sjogren's syndrome, the body attacks glands that make tears and saliva, so the most common symptoms of this disorder are significant dry mouth and dry eyes. Before we end this lecture presentation, I want to touch briefly on the topic of cancer and the relationship with cancer and stress. While many people refer to the stress-cancer connection, the research has been mixed. There's actually no clear evidence that stress directly increases the risk of cancer. However, there is limited evidence to suggest a link between repression, particularly repressed anger, and increased cancer risk. Stress may increase the rate of tumor growth and encourage the spread of cancer throughout the body, the process of metastasizing, which is a term we'll review on the next slide. There are numerous mechanisms by which stress may increase the risk of tumor growth and cancer spread throughout the body. One of these is the suppression of lymphocytes, particularly natural killer cells, that are important in the immune response to cancer. Also, increased blood flow and nutrients end up feeding the tumor, a process known as angiogenesis, which is the creation of new capillaries that are aided by glucocorticoids. Therefore, high levels of chronic stress not only suppress lymphocytes, but also aid angiogenesis, which is a 1-2 punch in cancer getting the advantage over the individual who is trying to fight it. Additionally, increased glucose in the bloodstream further feeds the tumor and allows the tumor a nice, healthy lifestyle, which is, of course, the opposite of what we would want for the tumor. We want to be starving the tumor of sugar and other nutrients so that it doesn't have what it needs in order to grow. Stress also encourages poor lifestyle choices, particularly if the person has limited coping skills. This further increases the risk of poor outcomes. That may be poor sleep due to stress, relational issues, poor food choices, substance use, a sedentary lifestyle, and again, coping in ways that may be problematic, such as through repression or through some of the other mentioned factors, such as substance use. Protective factors relate more to social support, quality medical care, and healthy lifestyle choices. People who effectively manage their stress following their diagnosis tend to experience reduced spread and tumor growth. But of course, this is only one small part of the puzzle, and individuals who do experience tumor growth and/or tumor spread are not necessarily poorly managing their stress. There is much more to the clinical picture of cancer risk than stress management. With that said, effectively managing stress following the diagnosis is associated with reduced spread and reduced tumor growth, which may aid the person in being able to overcome the cancer. We'll finish off this lecture presentation with a brief overview of terminology related to cancer. First, oncology refers to the study of cancer, and an oncologist is a doctor who specializes in the diagnosis and treatment of cancer. A tumor is an abnormal mass of tissue. Tumors are not necessarily cancerous. They can be benign, which means it is not cancerous, or malignant, a term that means cancerous. In situ is a cancer that has not spread to nearby tissue and is therefore non-invasive. This is preferred over a cancer that has metastasized. Metastasis is the technical term for the spread of cancer from one body part to another and is associated with increased risk of poor outcomes. The stage of cancer is the extent of cancer in the body, based both on the size of the tumor and whether or not it has spread to other body parts. It ranges from 1 being the earliest and least severe to 4, the most advanced and the most likely to be fatal. Carcinoma is a cancer that starts in the skin or tissues that line the inside or cover the outside of organs. Leukemia is a cancer of the blood. Lymphoma, cancer of the lymphatic system. And lastly, sarcoma, which is a cancer of the supportive or connective tissue, including fat and muscle.